Today we'll discuss about orthognathic surgery. First, we'll go for the patient evaluation, and then we'll plan the treatment and which osteotomy to be taken place. Okay. So orthognathic surgery is the art and science of diagnosis, treatment planning, and execution of treatment planning by the combination of orthodontics and oral and maxillofacial surgery to correct musculoskeletal, dento-osseous, and soft tissue deformities of the jaw and associated structure. So it is the combination of the primary combination is of orthodontics and maxillofacial surgery. Okay, then it has a sub branches just like cleft palate and all. So basic therapeutic goal of orthognathic surgery is function, aesthetics, stability, minimizing of the treatment time. Specific therapeutic goals are correct masticatory or swelling abnormalities, establish functional occlusion through the normalization of the occlusion relationship, overbite, overjet occlusal plane, angulations, and transverse dimensions, they are corrected, and correction of the associated TMJ dysfunction, pathosis, or pain. It also corrects the structural abnormalities resulting from over to underdevelopment, decrease or eliminate myofunctional pain or headaches, then correct abnormalities related to respiratory compromise. Correct speech problems, hyper or hyponasal speech, velopharyngeal incompetence, articulatory speech dysfunction, improve stability of orthodontic results, improve dental and periodontal results, improve psychological impairments. Diagnostic factors and risk factors are the type of congenital or developmental deformity, and type of acquired deformity, systemic or localized condition or disease that may interfere with the normal healing, type of malocclusion, then respiratory problems, sinus or nasal airway disease or pathosis, and speech problems. TMJ dysfunctions or pathosis, masticatory swelling difficulty, psychological impairment, bone soft tissue pathosis, types of musculoskeletals or dentofacial, dento-osseous deformities, then abnormal osseous or soft tissue anatomical characteristics, then compromise vascularity and at the surgical site. Other risk factors are infections, bleeding discresis, allergies, hypersensitive to surgical materials, then ocular or orbital deformities, severity of aesthetic deformity, poor patient compliance, neuromuscular abnormalities. Now, the patient evaluation is divided into a chief complaint or the patient concerns, whether it is aesthetic or functional, then clinical examinations, radiographic imaging and analysis, and dental model analysis. Then what are your concern problems? Have you had previous treatment for this condition? What has been the outcome? Why do you want the treatment? What do you expect from the treatment? And motivations, whether internal or external. So the facial examination with the help of cast, articulator, and STO is prepared. Then oral examination, functional examination, gnathological examination, cephalometric conversation, and surgical cephalometric analysis, which comes under the planning and all. And you have to take the frontal analysis also, like COGS and all. Okay. So aesthetic evaluation is the front of the aesthetic face, symmetry of the face. It is very important. It should be bilaterally symmetrical. Balance upper third of the face, middle third of the face, middle third of the face, and lower third of the face. It is divided like this. So this is the from hairline to the this point, frontal point, then to the nasal point and to the chin. Then middle, this face is again divided into from the intercanthus line. This is the intercanthus line. Okay, this is the outer canthus line. Okay, and this is the outline of the face. Then frontal face aesthetics, the width of the nasal dorsum, that is very important. It should be the half of the intercanthal distance. And form and symmetry of glabella, dorsum, tip, LR bases, LR width, nose length, they are assessed. Frontal face aesthetics, cheeks, symmetry of the malar eminence, infraorbital rims, paranasal area, projection of the malar bone eminences, ear symmetry, level, projections, deformity, and partial agenesis. Sometimes you have to evaluate that. Frontal face aesthetics, lower third of face, subnasal stomion, should be ratio of the 1:2, then subnasal vermi and vermilion gnathion 1:1. Now lips, yes, symmetry at the wrist, smiling, upper and lower vermilion 1:1.25. Then interlabial distance should be 1 to 3 millimeters, 0 to 3 millimeters, and commissure width should be 55 mm. Teeth exposure at rest, smiling, dental symmetry, and midlines you have to check. Sometimes you have to go beyond the these laws, because sometimes in some patients gummy smile, they don't like the gummy smile, but in some patients gummy smile suits them. Like one of the our this Bollywood actors and all, they have some people, they have gummy smile and it suits them better. So these rules and is according to the choice of the patients. Okay. Frontal face aesthetic, chin symmetry, shape, mandibular angle symmetry. See, you have to give the symmetry to the patient. Okay. Then do what patient want aesthetically. If it is possible, you have to explain the patient. You don't have to buzz the treatment on the patient. No, this is symmetry. This is not the symmetry what you are asking for. No, if the patient is asking for something, then maybe he's satisfied in that. And that is the definition of aesthetic in his or her sense. So you have to provide that thing. Okay. Then profile and aesthetics, you have must been learning in the orthodontics also. Upper third face, frontal bossing, supraorbital rim projection, glabellar angle. Middle third of the face, nasal bridge projection, dorsum prominence, nasal tip, columella and nasolabial angles. Eyes, lateral orbital rim projection, infraorbital rim projection. Cheeks, malar prominences. Lips, labiomental fold. Then submental neck areas, neck and chin areas. So normal dentals and skeletal relationship is like this. Everything is in the order, but when malocclusion solely due to maxillary protection, the maxillary protection is there. Okay, so this line is disturbed. Then due to mandibular protrusion and retrusion plus deep bite. So these are the various things: deep bite posterior, anterior, like this. Combination of maxillary and mandibular. You see, maxillary is here retruded and mandibular is protruded. So it is a class 3. Okay. Then in radiographic evaluation, sinus pathologists should be evaluated first. Then bony pathologists, TMJ pathologists, impacted teeth, periapical, periodontal pathologies, dental caries, masticatory muscles and TMJ evaluation. Then muscles of mastication, mandibular movements, TMJ symptoms on loading and movement and rest, and signs of TMJ like popping or creps. Now this is a type of class 3. Okay. The combination of maxillary and mandibular, maxillary retrusion and mandibular protrusion. Intraorally open bites are there and crossbite is there in the anterior region. This is the hard tissue tracing of the person. So you will find here the crossbite and all the angles they have shifted. Okay. And this is the soft tissue profile of that patient. So when you are doing hard tissue analysis like Boston's hard tissue analysis, The cranial base and the horizontal skeletal areas, they have some these type of findings that it should be 29 millimeters, and the skeletal findings are when at the point N to point A should be -5. In this case, it is there, but it should be like plus minus 3.7 maximum. Okay, so just like that, vertical dimensions are also not correct in this case. So we'll what the planning is done, that the first planning is you do a mandibular osteotomy and put the mandible back, or do a maxillary osteotomy and slightly take the maxilla out. Then the compensation is definitely done with the orthodontic treatment, the dental compensation. So these breast and soft tissue analysis and breast and hard tissue analysis is done specifically for the orthognathic surgery. There is another analysis called Grumman's analysis that can be done from the frontal area. Now in this case, maxillary vertical height is more. So this osteotomy should be an upward osteotomy. Narrow arch. So as you say, see, the maxillary height is more. So these are the findings of Western analysis in this case: horizontal and vertical, maxilla to mandible, dental and soft tissue analysis. Then model surgery is planned. The model is poured with the articulator, and after that, osteotomy is planned. In this case, maxillary osteotomy is planned. And I'll show you the other treatment planning and of orthognathic surgery. So this is the example that what is the face is the identity of the individual. Again, this definition is see, basically these are two different presentations. I'm clubbing them together. So again, definition, genesis, and these are covered already. So in this, some clinical photographs are there to explain like this, less theoretical, more clinical, like prominent chin in this case, and in this case, retruded chin is there, convex profile, concave profile. Then in diagnosis, yes, with the help of all diagnosis, surgical and these phases are there. Treatment planning is done with the conservative, myofunctional appliances and orthodontic treatment. Then surgical phases of management is pre-orthodontic phase, pre-surgical phase, surgical phase, and post-surgical phase. So pre-orthodontic phase and post-surgical phase can be done by orthodontists. So osteotomies of maxilla, single tooth osteotomy, anterior segmental osteotomy. So in anterior segmental osteotomies, now these are the various osteotomies which are done by the surgeon. Okay. So first one is single tooth osteotomy. If single tooth is at the different angle, so single tooth osteotomy can be done. Then anterior segmental osteotomy, anterior segmental, only canine to canine. Okay, so 4 is extracted. If there is a pushback of anterior maxilla, 4 is extracted in that case. Okay, so there are two procedures in this: Wassmann procedure and Wanderer procedure. Then in posterior segmental osteotomy, LEFO1, LEFO2, LEFO3, whole of the maxilla can be pushed backward or forward. In LEFO1 osteotomy, the indication is lower mid facial hypoplasia is there. If maxillary hypoplasia is vertically short and long face. The complications are injury to the Stenson duct, very common injury in this, infraorbital nerve and maxillary artery. Now in LEFO2 and LEFO3 is the high level osteotomies, seldomly done, but they have a reverse prognosis also, because sometimes you do the osteotomy and it can again push back with the force of the muscles. In osteotomy of mandible, ramus osteotomies of mandible, including the symphysis. Then if you are not involving the dental components, then only genoplasty can be done. The osteotomy with the posterior positioning of the mandible, like sagittal split osteotomy, double sectioning of horizontal sliding genoplasty. This is a sliding genoplasty. Okay, reduction genoplasty. See, in sliding genoplasty, we need for the retruded mandible, we need to protrude it. The chin should be protruded. In reduction genoplasty, already the chin is more. So this part is removed and this is rated well so that the protrusion of the mandible, it goes back. Okay. In vertical augmentation reduction genoplasties are there. Bilateral sagittal split osteotomy with the dental component, the mandible is moved forward or backward. So these osteotomy, first the horizontal osteotomy is made at the outer border. Then from the inside, one osteotomy is made above the inferior amoebial canal bundle. And then plating is done from the lateral side or buccal side. So these are the main osteotomies of maxilla and mandible, like single tooth, anterior maxilla, posterior maxilla, genoplasties of mandible, and then the total mandible setback or push forward. Okay, so this concludes the insight of orthognathic surgery. It's a vast field, maxillofacial surgery, and these types of orthognathic surgery and all. It is done in conjunction with the plastic surgeons and all, because it's a matter of aesthetics, and main planning in orthognathic surgery is done by orthodontist, and the oral surgeon only. See, on table, the patient is yours. So you have to be of thorough knowledge of the facial profile and all, and do what is right, do what your patient wants. Okay. Thank you.